right?
Right.
Okay. Didn't get that on tape, did you?
Yes, you did.
Anything about suctioning?
We don't know nothing.
So what we're going to do for our checkoff is what we call endotracheal tube suctioning. I think it's the best one to make sure you know how to do most everything. Nasotracheal would be a little bit different in that we just talked about. You'd be going through one nares, and then you're trying to feed the catheter essentially just about where this tube would end up. Okay, it's probably more difficult, but it's just really not something you can get a good feel for, I think, by doing it on a mannequin. It's another one of those things you have to do on a real person to really get a sense for it. So if that comes up, it doesn't come up that often, but if it comes up, I would say just have your instructor help you and work with you to do it, because it's the first couple times you do it, you definitely want some help, I think. The other type would be like a closed suction system type, where the person's on a ventilator, and you'd have a suction catheter essentially is already attached and just stays there, so we're not breaking open the circuit routinely like you would be with this kind of suctioning. And then that's not too hard to scale down from. It's actually pretty easy. It's a lot easier than what we're going to do for our checkoff. Another would be trach suctioning, where the procedure is pretty much the same as what we're going to do here, but instead of having your catheter go through an endotracheal tube like this, you would go through a tracheostomy tube. Probably the biggest difference would be you just don't go as deep. Okay, a lot of people with tracheostomies will sometimes tell you, don't go so deep. You may not even have to get them to cough. Sometimes they'll just cough because the mucus is there. They'll cough it up, and you just need to kind of stick the catheter down and get it out of there for them. So it's like a lot of other things that we've talked about. You really have to play off your patient, because it'll be different depending on the patient. I mean, we're going to do it a certain way here with this mannequin, but once you get into I'll say the real life, okay, with real patients, it's going to be a little bit different. Now, one of the things I kind of want to do before we start is put this guy's head up a little bit. I like to have their head up pretty good when I suction. Like I said, if you're going to do nasotracheal suctioning, I think it's a good idea to get the head pretty high, into a high Fowler's. I don't know if I should. All right, this isn't going out for public consumption, right?
No.
But one of the things you can imagine is if they're back like this, the tongue's going to be much more in the way. So if you get them sat up, the tongue will be less of a problem. If you're doing nasotracheal suction, tongue's not going to be a problem here with the ZT tube in. The tongue's out of the way because the tube's in.
You take the nose out from behind the head?
It depends. Whatever it takes to get them. This guy's pretty flaccid, so he's not cooperating and just kind of sagging back. It's okay. I have an airway in. I'll get down there still, I know. I put this tube in the other day. I know where it is. I checked where it was, unless somebody's been playing with it since then. Wait a minute. Second-year students were in here yesterday, weren't they? Uh-oh. All right, well, we'll find out what happens. The story I was going to tell you one time is I was with a surgical resident, and he wanted to nasotracheal suction the guy. And what he did is he took a gauze, reached in, pulled the guy's tongue out, just out, not off, okay?
Gently.
While I was going down through his nose to try to get in the trachea, because he was obtunded, his tongue kept getting in the way. And I was the whole time I was doing this, please don't bite down, please don't bite down. I wouldn't recommend doing that. There are other things you can do. You could put an oropharyngeal airway in to get the tongue out of the way. You could put a nasopharyngeal airway in to get the tongue out of the way. And maybe, if it's somebody we're suctioning a lot, in fact, I'll be honest, I'm being honest again. I'll be open with you. My experience is, primarily when we put a nasopharyngeal airway in, it's for nasotracheal suctioning, because then we're going through that airway and we're not banging against those turbinates or concha over and over and over again. So it provides us a nice conduit to get down into where we want to go. So that's something to consider if you're doing lots of nasotracheal suctioning, is just put a nasopharyngeal airway in, and it'll make things go a lot easier. If you're doing it once, I probably wouldn't. I'm going to take this kind of slow, just so we can go through everything. Equipment is not really that there's not that much equipment, because you're going to have your suction kit. With most hospitals are going to have a self-contained suction kit. They're going to have gloves. They're going to have the catheter. This one happens to have a container of sterile water. There's a little paper towel type thing in here. I like to do, if I'm going to take them off and I'm going to suction, I like to put something here. I think the nurses appreciate it too, that you don't get a lot of mucus on their gown or whatever. So if I don't have a towel, I get a cloth hand towel out of the linen closet or whatever and put it there just so I don't make a big mess. I do the same thing when I extubate. If I'm going to pull this tube out, and especially if you're going to pull a gastric tube out also, have something here because it's going to be pretty messy. And I just assume they have a nice clean gown when I leave, especially if they had one when I came in. It's a way to keep a nice working relationship with the rest of the people that you're going to work with. Now for this suctioning, and if this were tracheal suctioning, it'd be the same thing. We want a resuscitation bag hooked up to oxygen. And that's, for the most part, that's the only equipment you need. If you're doing closed suction system, it's already hooked up, it's ready to go, but I would recommend putting gloves on still, even though it's closed, because sometimes it comes apart or whatever, and you want to. The other thing with this, you may want to wear your eye protection that we talked about. It can spray, okay, and depending on, you know, I've already told you not to look down the tube when you have it disconnected, or the trach, but it can spray a little bit, especially if you're going to instill. All right. Confirming the proper size suction catheter. Endotracheal tube, typically what I do is, this is a size 8.5. I just double that. So 8.5 times 2 is what?
17.
So that would be the biggest suction catheter I would want to use, 17. Biggest I've ever seen is a 16. Most of the time, you're just going to be limited in what your hospital stocks. Okay? Especially kind of now. It used to be, in the olden days, we'd get our suction catheter and our gloves and everything separate, but now you get a two-package deal. What size suction catheter would you say is in there? Lucy, can you tell?
Need my
Find it
glasses
on the
maybe?
label. Go ahead, yeah. 14 French. So suction catheters are in French sizes. 14 is a pretty good standard size for adults. So if I was going to do nasotracheal suctioning, I'd probably use the 14 also. Maybe a 12 if you had them available. So make sure you're, and that's how you check, is you basically read the label. Putting on gloves using sterile technique. This is where a table would come in handy. Now you guys know I'm breaking my own rule. I'm using the bed as a table here. So inside the kit, we have gloves.
Everything in there is sterile.
Gloves need to stay sterile. You have sterile water, which the water inside needs to stay sterile. And my catheter, I don't really want to mess with yet at all. I guess maybe the thing you'll learn here is find a nice working space. I'm not sure. We'll see how this chair works, but it's already looking like it's going to be a little small. All the patients should have a nice sized bedside table that you can pull over and work with. Part of the issue sometimes is their breakfast tray is still on there, their water jug is still there, their newspaper. You might have to clear some things off, but try to get, you know, I don't like you to use the bed, because there's probably, like we talked about, there's nothing more dirty, so to speak, in the room than probably their bed. The hardest part of the whole check-off is probably putting your gloves on.
I love doing that.
Especially if you're trying to keep them sterile. So what needs to stay sterile, the inside or the outside?
Outside.
The outside.
Okay, so the inside, once you put them on your hands, which you have already washed, right?
Exactly.
Okay. Let's see if we can do this. You might want to stop and think about, okay, what should I do? Should I start with, am I going to do this right-handed or am I going to do it left-handed? In other words, one hand is going to feed the catheter. That's usually your dominant hand if you're good at pointing that way, or good at feeding that way. Now, there are certain things. I've done punctures left-handed. I've suctioned left-handed. Sometimes
Yeah,
you just have to
dexterous.
use your offhand just because of the situation. You guys okay back there? You gonna be all right standing up? Okay.
Eating beef jerky.
So, and if you can see this, which part of the glove, and I've already given it away because I've already contaminated part of it,
It's
is
inside.
going to be dirty, if you will, or
Part that's
unsterile.
The inside.
The inside of the cup especially, okay? So, and I'm going to over-dramatize just because I'm on TV. You know, you can touch this part as much as you want. The part you want to refrain from touching is the fingers especially. So, just because the way I've done it for years and years, I usually put my dominant glove or my right glove on first.
Those
The
look
other
kinda
tricky
small.
part, yeah, this could be tricky, is getting your fingers
Fingers in there.
in all the finger holes.
Especially when the pinky's all the way around the back.
This is why I'm somewhat sympathetic towards you guys when you're doing this. And
It just, what size glove do they typically put in the kits? Small.
remember, I said this was the toughest part. Now, I'm trying to, as much as I can, grasp it here. The other thing I'll warn you about is,
I almost got a thumb through there.
because I think I have my thumb in the pinky hole.
That's right.
And that's on TV.
This will be good on
You
YouTube,
do
won't it?
that.
You're YouTubing it.
All right, now this is probably the tricky part. I stay pretty sterile here.
You're
This is
doing all
where
right,
people
Larry.
get into problems. The best thing to do here is kind of cuff the glove and underneath here. It's all sterile now, right? But when the tricky part is, and I may do this wrong on purpose just to make it look bad, is when you start touching, in other words, I can do this and just wrap it over. I may want to try to get them right. And watch, the harder one's going to go on easier. It goes on a lot easier when you have it lined up. Now the other thing too, these are pretty good because they're fairly new, but if you get older gloves or something, it's real easy to rip right here. All right, so I've done a pretty good job, 50%. The other thing I will tell you is, this gets back to that
Take off the
old
glove.
stuff. We didn't put a glove on our offhand. All we did was put a sterile glove on the hand we were going to use. Okay, now, I can open this up because it's still sterile, right?
Yes.
The apple juice containers are good.
Mm-hmm.
And be a
Yep.
little careful. I'll also warn you too, although we've talked about the bed, don't put any open container of water on a patient's bed or on a table over the bed, because speaking from experience, it can get knocked over.
It does.
Let the other healthcare practitioners give the patient a bath, okay? All right, now it gets to be a little bit tricky because the part that really needs to stay sterile is my catheter. Now, what's not going to be sterile eventually?
The red
The red
part.
part.
So, again, my offhand, I'm going to take my sterile hand, or what's going to stay sterile, because this hand's not going to stay sterile. I'm going to wrap it up and contain it a little bit so it's not flopping all over the place. Okay? This is hard to do when you actually talk about it.
So is that not sterile now?
No, it's sterile.
This hand?
That hand's not sterile.
His
That
little-
hand's
What did I do
not
there?
sterile.
Your right hand is not.
That's a good pickup, Sean. Is this hand sterile anymore?
No.
No, it's
This
not.
is my offhand. I just contaminated it.
That's his
I
left
can't
hand.
touch anything that needs to stay sterile with this hand. So I can't, and now I didn't want to touch it with this hand, right? All right, so how much suction pressure do I want? Oh yeah, that's right, you guys are starting from scratch.
80 to 100.
I usually go a little bit on the high side. Adults, we do 80 to 120, okay? And really, I like to do it if you plug it, and with some experience, you'll be able to tell. That's just
The water's moving in
Since
there.
this is off the record, I was trying to make a video of arterial puncture once, and I didn't open my gauze package ahead of time, and so I was holding pressure, and I had the sample, and so I kind of bit the paper off my gauze. Well, we won't use that one for
What not to do
consumption.
video.
So I don't want, when I have it totally occluded, I don't want to see my pressure go above 120. Okay? And the other part, I think, now that I think about it, because I've done this a million times. You're not going to do it as much as we used to because you use the closed suction with all your ventilator patients. Is this also helps me remember which of my hands needs to stay sterile. I've kind of occupied this hand, and then I just take it like this, and I use, again, that's not going to, because I'm going to occlude my port when I suction. So now my red part's not sterile anymore either. I like to have you check your suction. Good way to check it is to go ahead and put this in, and then make sure it suctions the water up.
Yes, it does.
Makes that nice water suction sound. I'm kind of going off the sheet now because I turned my oxygen on, probably about 15 liters. Okay, but I'm going to turn it back down. But normally you'd leave it at 15. This is a part that is a little bit difficult too, and some people would say this needs to be a two-person job for this reason, but you may not always have a second person. So I need to ventilate this person with a high level of oxygen before I suction them. Okay? So what I've always used is the back of my arm. And that should be for a good minute. This is where your pulse ox will come in handy. This person's in ICU. They have a continuous pulse ox. It's 94%. I usually like to get it up to a little bit higher because I know it's going to drop when I suction them. I guarantee you it's going to drop. So get their pulse ox up to nice, comfortable, high level.
So you do that for a minute?
A minute's what your checkoff says.
Do you want us to do a minute?
Certainly not 15 seconds. That's good.
Said more than 30 seconds. Use mechanical.
And then the other pass is, remember, if I get stuck here, I cannot use this hand, so I have to kind of slide and disconnect that way. Patient looks good. The heart rate looks good. So now I'm ready to go. All right. Usually you have a little curvature in your catheter.
On the bed just like that, or would you hang it?
Well,
Like that's...
I would probably. It depends what you have available. Thank you, Sean.
That's the points I always lose on.
Yeah, you're right. So now, how long do I have? And I'm going to take a little bit longer just because I'm demonstrating. 15 seconds, all right, from the time, essentially, I take them off the ventilation.
15 seconds.
Okay. And I use most of your time coming out, all right, so you want to get down really fast. I'm going to go again. I wouldn't normally do this, but just so for demonstration. Get your curve. Try not. This is not what you're supposed to do. Don't bang the catheter on the outside because that's really dirty, okay? So try to get your catheter once you get it in, and then kind of feed it like this. And then really quick, and then notice I haven't applied suction until I get down. You're going to feel the carina. Your patient's probably coughed really hard by now, or at least most would. You pull back a little bit, then you apply suction, and then you come out. Okay, and then you let go every so often, so part of it's not to adhere to tissue, and then you kind of want to grab your catheter as it comes out, because I'll show you what happens if you don't do that. And then I wrap it up again. Now this is a question that kind of comes up from time to time. Depending on how your patient's doing, if they've desaturated a lot, I want to give them some oxygen fairly quickly.
If they don't?
And then if they're doing okay, because what's in here and what's on the end of here, maybe?
It's on the end
A bunch of mucus, right?
Yeah.
So I want to clean this off. So that's the order issue. Do I do this first, clean it off, then ventilate them, or do I ventilate them and then clean it off? Well, let's say he wasn't doing very well, so I ventilated him. Got his pulse ox back up. Now I'm going to clean the goobers off my catheter. Okay, and I'm going to assess whether I need to make another pass or not. Now I do that maybe when I ventilated him, I still felt like there's mucus down in there. You can wear your stethoscope. It's somewhat impractical. But you could wear your stethoscope and maybe just have it so it's clipped on your neck, and you can just, because you need to keep this hand sterile still. So one-handedly put your stethoscope in your ears. Again, with some experience, and these gloves definitely are not big enough, especially backwards. With some experience, you can kind of tell whether they need to be suctioned again. But just for today, I'm going to go and do another pass. So before I made my pass, I reoxygenated him, got my catheter clean. I don't want to stick old goobers back in there. That kind of defeats the purpose. Again, I'll try to go a little faster. Got it in. Use most of your time coming out. Get down really quick, pull back, and then slow down a little bit coming out because you want to suction him. You don't want to leave a bunch of stuff in there. And 15 seconds is a lot longer than you think. Most people say if you hold your breath and you start feeling it, that's 15 seconds. You can sing if you want to, happy birthday to you. That's about 15 seconds. So again, the other way you could do this, and again, let's say, okay, I came back out, I didn't get a lot of secretions, I don't think I'm going to have to make another pass. So then I would definitely go ahead and hyperoxygenate him again and not worry about cleaning the catheter. But let's say I know this guy's got a ton of gunk down there, and that's respiratory therapy terminology there. He's doing okay. I go ahead and clean it, get it all nice and clean, and then hyperoxygenate him, and then make another pass. Okay? So, if I made another pass, the last thing you should end up doing is hyperoxygenating him again.
That's after you're
And
done
for your
sucking.
checkoff, typically, we're going to do 2 passes. So, and then what I would do is, and I'm probably going to have some tubing, I think, hooked up like he's on a ventilator. We won't have him on a ventilator, but just some tubing to deal with. And put him back on his oxygen or ventilator, whatever the case may be. Then if you haven't, rinse your catheter out again. And then get his mouth.
Oh.
So you want to go kind of deep and get the back of his throat, because when you can't swallow very well, you pile stuff up back there, mostly old saliva. But since we've gone to the closed suction systems, what I've noticed is people aren't getting the back of their mouth very well. It used to be just part of our practice. You get the mouth when you're done, but you have to get something special to do the mouth now. So, but I would strongly recommend you clean it off before you get the back of your throat. I mean, it's not going to hurt them, but I think most of us don't want to eat our own boogers. I mean, you're eating it right now. You just swallowed some, probably. It's almost
salty.
lunchtime.
It's lunchtime.
Put them back on their oxygen. Now, what kind of assessment are we going to do here? We can do a very good job with that, and it's
Breath sounds and respiratory rate.
before we suction him. What kind of assessment do we want to do? Breath sounds are almost crucial, because how often are we going to suction somebody?
As needed.
As needed.
And how am I going to know if it's as needed?
You're going to listen to
Saturations, breath sounds.
sounds.
Sometimes you can just see it coming up in the tube. There's a lot of mucus. If he's on a ventilator, when he gets a breath, the mucus goes down. When he exhales, it comes back up.
what kind of breath sounds you're going to hear.
Crackly,
Crackly.
bronchi.
Number 10. What's Monitor's patient response?
Okay.
Monitor's? Is that how you pronounce it? Monitor's? That's what he says.
Oh. spaced out.
Monitors.
Monitors. That's Latin, don't you know?
Yeah. Alright, never mind.
Well, no, that's a good question. How are you going to monitor during the...
Well, I have a continuous pulse off.
Yeah, saturation
That's
is wonderful because we have it now. If they're on the floor, this would be one of those cases, I think. Okay, if he's out on the floor and not on a continuous pulse ox, this is one of those cases where, you know what, I'm going to hunt one down, and while I suction him, I'm going to leave a pulse ox on him. That's that critical thinking we talked about before. This is a procedure where I think the risk is high enough that we want to monitor his saturation when we do it. Some of the aerosol therapies you're going to do on people, you may not need a pulse ox before, during, and after. But I think this one is severe enough, potentially hazardous enough. You know, vitals are nice. You know, are you going to let's say they're not on a monitor, are you going to take a pulse before, during, and after? It's probably a good idea, but I don't know that you're going to do it. If the person needs to have their airway cleared, you're going to do it regardless of what their vitals are. it does give you an idea of, okay, I need to do it quicker, I need to oxygenate them more when I'm done, or I need to oxygenate them more quickly. You know, the typical case would have been that, you know, if somebody you know is not going to breathe at all, if they're on a ventilator and you have to take them off to suction them, and you know they're not going to take a breath the whole time, you better not be doing a lot of monkeying around, because they're not going to take a breath on their own at all.
So you got 15 seconds.
Yeah.
Basically.
You got 15 seconds for the whole suction. I mean, but in that 15 seconds, you should have hyperventilated or hyperoxygenated. Really, you probably do a little hyperventilation too, but and hyperoxygenate them again. So 15 seconds between hyperoxygenation, you could say. Sean,
Do you, when they're on the ventilator and they're intubated, do you sit them up to check their lungs up front and back? Check
if you
all of them?
can. You know, we talked about if you're by yourself and they weigh 400 pounds, it's going to be real difficult to get them, and they can't help you at all. Sometimes it's a matter of tucking your stethoscope as far as you can underneath them on both sides. If somebody's in the room, and that's something to acknowledge a little bit, if like a physician comes in and wants to auscultate, you can help them sit them up or whatever. Yeah. Usually if they're on a ventilator, a lot of times it's a little easier to hear breath sounds because they're getting fairly good-sized breaths. So ventilator patients are good ones. You know, if you guys have some learning time at clinical, even this semester, ask the instructors, you know, can we go listen to some breath sounds on some ventilator patients, because they're pretty, depending on what settings they're on. The guy the other day might not have been much better, but. Stephanie, do you have a question?
Do you sometimes have another person with you when you suction that can, as soon as you pull out, they can...
Yeah, that's why ideally, I mean, if you were going to be in a perfect situation, you'd have two people doing this.
And one hand really seems like it would take...
It takes some practice. And then you'll find out at Methodist, they use the anesthesia bags, which almost take two hands just to run the bag, or the resuscitator.
You don't want to touch the carina, do you?
Well, theoretically, now, there is some debate on that, especially with babies. We've gotten away from hitting the carina, so we actually have pre-measured catheters. And you can see how this one has markings on it, so I would know how far to go down. Adults, we're still, I don't know if it's compassionate at all, but a phrase some therapists will use is bang catheter off carina. Instead of suctioning, I'm going to go bang a catheter off that person's carina. But they did look at tissue, like on post-mortem on some babies, and they found that if they were suctioned a lot, they were mincing up their airway a little bit. Adults are probably a little bit more tougher and resilient, but the babies, we try not to do it as much anymore. I almost go by as much. I mean, why are you hitting the carina? If you can get them to cough before you get there, I think you've accomplished what you need to do. Because the cough, you know, if you have somebody like this, they'll cough and they could pretty easily hit that ceiling. If you see somebody in a room and they've been in that room a lot and they've had a lot of open suction like that, you look up at the ceiling, got little green dots on the ceiling. So again, I think I told you the story, and the nurse was standing about where Chelsea was, and I was suctioning like this, and he coughed hard enough that it just went right by the catheter and nailed her right in the cheek. She wasn't looking. Nice. She was walking. I think she was walking by.
At least she got the cheek, not the front.
So, I would encourage you to wear whatever protective equipment you feel comfortable wearing. If you want to wear something with a mask and eye protection, go ahead. Again, most of our suctioning now, at least in ventilator patients, is going to be closed suction systems, so it won't be as... But if you have somebody with a tracheostomy tube on the floor, they may very well have to do this old-fashioned. And this is the one I like to do a checkoff on, because I kind of figured you can do this one, you can do all the rest. At least the hardest part, as you saw today, is getting the blasted gloves on and getting them on properly. You know, my hands hand's going to be like this for the rest of the day. It's going to be like crooked.
What if we can't get the gloves on? I don't think
Well,
those would even go
you know
on.
what?
I didn't
I
know
may
if we
have
were
to
gonna-
get some bigger gloves because I'm pretty sure some of you have bigger hands than I do, and these are kind of tricky. The other thing I will warn you about gloves, you maybe found this out. Make sure your hands are good and dry, because if they're still wet, you're not going to get the gloves on very well. Same with the scrub. Make sure that's good and dry. Otherwise, don't even bother trying to put gloves on. They'll just get stuck in. You'll have finger cuts on all. And that's as far as they'll go. So, a little bit more about the assessment. It's kind of the same. Breath sounds, heart rate, breathing rate. It's a little harder to do middle because you've got your catheter in one hand. This one's free. You can still get a pulse. You can still do a breathing rate. Yeah. Well, depending on the situation, yeah. You know, that's where, Stephanie, if somebody else is doing this for you, then you have time to do that kind of stuff. And the other thing, too, is if they're on a lot of PEEP, and I think your checkoff says something about using a PEEP valve, if we take them off, that's another reason we don't really take them off as much anymore. If they lose their PEEP, I don't know if Carrie showed you like videos and things when you talked about it. You can see the lung collapse when you take them off that PEEP, and then you have to reinflate the whole lung again. So it's a good idea not. There's a lot of good reasons why we don't do it. Infection control is the biggest reason that we don't take. Every time we open this circuit, there's a chance of contamination. But mostly, I wanted to get in the gloving part, and I'm not. This is off the record again, but I'm not that meticulous that you're picture perfect with getting your gloves on. You make a pretty good, honest attempt of. I mean, I've had situations at clinic where we've gone through 3 or 4 pairs of gloves before you finally, because when it's a real patient, I'm going to be pretty particular. But again, I think one of the most problems is they kind of contaminate what's going to be their sterile glove. Like maybe they pull it on and they brush against their wrist, and then they're going to touch this catheter. So
see, that one on your hand right there is driving me nuts on your sterile hand. That buckle on right at your wrist. I'd be losing.
Oh, my watch?
Well, no,
No,
on your
how
sterile
it's
hand,
rolled
that
under the
fold.
glove.
Oh.
Make me.
Yeah, I'm not so concerned back here, but up here I like to have the full glove. And the gloves don't, I mean, these gloves, the gloves I grew up with, they usually came down to about like here. And the other thing too is, you know, I have a long sleeve shirt on, which is a little more difficult, and I think that gets back to that long coat thing again. I think it'll be easier with just a bare arm like with scrubs to do this. Here I am a year later, and I'm an advocate for scrubs. I never thought I'd hear myself saying these things.
Number 4 says pre-oxygenates for 30 seconds. Is that what you want us to do, or you want us to do
Is
a
that
minute? That's the first.
initial?
Yeah.
Yeah, 30 seconds, I think. And again, if I have a pulse ox, I go by that. You know, the pulse ox is I'm giving close to 90%, 100%, probably not 100, but close to 90% oxygen here. Their pulse ox should go up pretty fast. 30 seconds if it's up to 100. The problem with pulse ox is that PO2 is probably at least 100. And it might even be 600. That's why the babies we do a little bit differently. We'll address babies a little more when we talk about that next semester. Any other? I kind of gave up on my. And pardon me for putting the bag there. It's just sometimes it's up here. It depends what you have available. I mean, if there's nothing like this, you have to kind of improvise.
How about number 6? Normal saline may be instilled.
Oh,
mobile
I almost forgot about that. How do you know?
Because I went to, when I did my job shadow at Child Serve, I asked him about it because when Matt said that he hated it, so I just had to tell him to get that.
And it's really okay. What instilling is maybe in between passes. I thought the mucus was really thick, so it needs some help. And we don't use water because water's kind of irritating, but we'd use normal saline, and like we used for our nebulizer treatment last semester for the fake albuterol, maybe a 5 milliliter vial. Those, I don't know if you saw the ones at the VA, but they have what I call the atom bombs, which are they're almost like an apple full of normal saline. And that's another reason I like the. And this didn't have the gown for me to put down. So our newer kits don't have that. But another reason I like to put that there is sometimes if I put saline in, it dribbles down a little bit. Always clean your patient up when you're done too. So let's. If what I typically would do is put it in just before I hyperoxygenate them again, and that would, yeah,
Work it down.
Good point, Jill, because I'm not, and that's where the controversy comes in. Some therapists are in the habit of just doing it every time. Okay, I prefer to do a first pass. If it's really thick, then I'll use it. Again, using your skills and your judgment to decide, not.
So you're lavaging them? Is that what you're trying
You're
to do?
basic lavaging them, yeah. So, and then I like to do it before I hyperoxygenate because that kind of pushes it or blows it down. And now, some studies will say all it does really is increase the risk of infection, but I mean, I had at least one time where I really do think we may have saved this guy's life, and we had to use normal saline because he had his tube, I think, was completely plugged with mucus, and we tried to suction him, we couldn't get it out. We shot a bunch of saline down there, bagged it, got it loose, got it thinned out, and we were able to get it cleaned out. We didn't have to extubate him, put a new tube in, or anything. So I'm not quite as maybe as far as Carrie is, although I think we're probably on the same wavelength more than it sounds sometimes. In other words, some people would always do it, and some people would never do it. But I think we do it in general. We do it too much.
Really?
I wouldn't advocate